Hi, my name is Carrie Eggins. I'm going to be doing a verbal soap note on a client, MK, who was seen at Hometown Healthcare on March 13th. My preceptor is Anna Lucas. MK is a 74-year-old Caucasian married English speaking female. She's an established patient at Hometown Healthcare and holds her primary insurance coverage with Medicare. The chief complaint today is my legs and feet are swollen and red. The patient presents to the clinic with a complaint of edema to the lower extremities bilaterally with erythema times 4 days. She states that there is little to no pain bilaterally at this time and rates the pain 3 out of 10. The pain is described as intermittent when walking and dull in nature. The discomfort is primarily noted to the area of the shin and below without radiation. She states that her socks and shoes are starting to fit tightly and that they leave a ring around her legs when she removes them. She has not taken any over-the-counter or prescribed medication for the edema or redness or discomfort. She has, however, been soaking with Epsom salt and keeping her extremities elevated. The discomfort is worse when walking. However, rest and elevation does reduce the edema. And to date, nothing has helped with the redness. She mentions that she has had some loss of sleep from having to sleep on her back and keep her legs elevated. She denies having any trauma to the area, any injury, insect bite, or allergic reaction. She does report that in the past she had 2 abscesses in the axillary area several years ago, and she was found to be MRSA positive during that time. In terms of her history, she has hypertension, seasonal allergies, hypothyroidism, and anxiety. Her surgical history only includes a total hysterectomy in 2006. Health maintenance, all of her vaccinations are up to date, and at her last wellness visit, it shows that her mammogram, she had a colonoscopy and a bone density scan all within this past year. She only has an allergy to penicillin. Her medication regimen includes Zyrtec, Wellbutrin, and Synthroid, all taken once a day, and Norvasc 5 milligrams taken BID. Social history, she's a married female. She lives at home with her husband. She's a full-time caretaker for her husband who has Parkinson's disease. He is on hospice. She's a retired school teacher with 3 children. All 3 children live out of state. She has assistance from the hospice nurses and aides with her husband 3 times a week. She is very active in her church that is near her home. She is Baptist. In the free time that she does have, she likes to um, tend to her plants and things of that nature, read. Her children recently installed cameras in her home as well as an alarm system so she feels safe at home. She denies any smoking, alcohol, or drug use. She says that she does have issues with anxiety and not being able to care for her husband or do her daily activities around the house as she would with her legs being her having issues with her legs right now, and just being able to sort of talk through it with her daughter and pray about it, that has helped with her anxiety. In terms of her family history, her mother died from lung cancer at age 71. Her father is deceased. He died at 63, with his only history included coronary artery disease. She does not have any information on the history for her maternal or paternal grandparents. In review of system, the patient denies any fatigue, fevers or chills, under skin, hair, and nails, she denies rash, lesions, wounds, incisions, reports edema and redness to her lower extremities. Head and neck, denies headache or dizziness, concussion. I'll continue through the review of systems and just address anything that is out of normal. Otherwise, I'll just note them as within normal limits. So eyes, ears, nose within normal limits, mouth within normal limits, respiratory, no cough, denies wheezing within normal limits. Cardiovascular, the patient denies any palpation, shortness of breath, faintness, or changes in heart rhythm. Gastro and GI or GU, she denies any sort of incontinence, bowel or bladder changes. Musculoskeletal denies any stiffness or a decrease in her range of motion. In endocrine, the patient does report having hypothyroidism that is treated with her synthroid and is therapeutic, denies any other issues. Neurological, denies any neuropathy, numbness, tingling, weakness. And psychological, denies any difficulty concentrating or any body image disturbances. Otherwise, everything is within normal limits. For the vital signs, the patient's blood pressure is 134/80. Her heart rate is 74 with respiratory rate 18. Her SATs, her O2 SATs 96%. She's on room air with a temperature of 98.2. The patient weighs 157 pounds, putting her in the 40th percentile for her BMI. In terms of my physical examination, the patient is alert and oriented with a pleasant demeanor. There are no signs of acute distress. I will go through my physical examination similar to how I did the review of systems, addressing only in detail abnormalities. And so in her integumentary, it's warm, dry, and skin intact. Erythema is noted bilaterally to the lower extremities at the shin and tracing down to the foot and toes. The area is warm, slightly warm, and there's pitting edema noted +2 on the right and +1 on the left. There are no open wounds or weeping, and localized tenderness is observed on palpation. Head and neck within normal limits, eyes within normal limits, perla intact, no extraocular movements. Ears, external ears are symmetrical in size and shape with landmarks bilaterally. Her tympanic membrane is intact, pearl gray in color. Nose, nasal septum is symmetrical in midline. There's no tenderness on palpation. The nostrils are patent. Mouth within normal limits, uvula midline. Dentures are visualized and they are clean at this time. Hard and soft palate are visualized without abnormality. Throat is intact, pink at this time, tonsils +1. Respiratory, regular, no accessory muscle use during respiration, no retraction, and her lungs are clear to auscultate. Cardiovascular, the pulse is 74 with a regular rhythm. On auscultation, I can hear S1 and S2 without any adventitious sounds. Radial pulses match the heart rate. Her dorsalis pedis pulse is palpated 2+ on the bilaterally, and capillary refill is less than 3 seconds. The abdomen is soft and round, bowel sounds present. A musculoskeletal, she's independent. There is no shuffling in her gait. Her gait is smooth. The range of motion is intact in all extremities. There is no pain noted on dorsiflexion of the feet. She's alert and oriented in terms of neurological. Cranial nerves are intact with deep tendon reflexes are intact as well. We did not complete any labs today. In terms of differential diagnosis, we have cellulitis, DVT, and necrotizing fasciitis. The positives for cellulitis would include the edema, the erythema, the pain and tenderness on palpation. The positives for DVT, I didn't have negatives for it. The positives for DVT would be edema, pain on tenderness of palpation, and erythema. However, the negatives would be there's no pain on dorsiflexion, there's no calf pain, no distension of superficial veins, or possible diminished dorsalis pedis pulses. Necrotizing fasciitis, positives, edema, erythema, pain and tenderness on palpation. Negatives, no crepitus on palpation, no intense pain, no localized sensory loss, no sloughing of the skin. So the diagnosis that I came up with is cellulitis. The diagnosis code L03.115. So the plan and what I used in order to diagnose this, the information is that most cases of mild to moderate cellulitis are diagnosed by clinical presentation and history. In some cases, acute cellulitis, there won't be any discharge or obvious wounds present. So we would not be able to obtain cultures. If there were an open wound, we would obtain a culture and a gram stain. If the patient appears ill or systemically symptomatic, then with things such as a fever, we could have a CBC done and consults with a different a infectious disease doctor if needed. And this comes from Dunphy. The treatment that my preceptor and I decided on was to start on Bactrim DS tablets, 800 to 160 milligram, one tablet orally, twice daily with meals for 10 days. Now, we did this medication because of the patient's history with MRSA. And so we decided, because she was at higher risk for developing MRSA, this was the best course of treatment. However, had she not had the history of MRSA, we would have gone with one of the other suggested treatments, such as augmentin or a cephalosporin. In terms of teaching, I spoke to the patient about maintaining the adherence with our medication regimen, making sure that she takes all of her antibiotics however we schedule. So she must adhere to the antibiotic dose, frequency, and duration of the treatment for the best results. Avoid any trauma to the areas. Keep the legs clean and elevated. She can use Tylenol or NSAIDs for pain relief if she doesn't have any contraindications to that. To follow up with the patient, we're going to follow up after 48 hours of therapy by telephone to check on how her symptoms are going, review her symptoms such as fever, if the pain has gotten worse, if any indications that there is increased inflammation. I've notified the patient that she should contact the clinic within 1 week if there's no improvement with the antibiotic use, and a follow-up visit will be scheduled for 2 weeks. The level of billing for this visit is 99212, and that is determined by different requirements such as history, exam, diagnosis, date reviewed, and risk factors. For 99212, the requirements are described for the history: one exam, one minor or established diagnosis, and one order or study lab data reviewed, as well as the risk that one minor problem required non-invasive lab, at-home based management. AAFNFP, describes this level of billing as requiring a chief complaint, 1 to 3 elements describing history of present illness, and an exam that is problem focused. In reviewing data for a level 2 visit, 1 point is needed to meet the requirement, which is considered minimal. 1 point can be earned by ordering or reviewing lab, radiology, or procedure reports, or by simply obtained records or a history from someone other than the patient, and that is from Waller 2007.